So funny story, this is actually the second time that I'm actually going to be recording this video. I actually didn't realize that my microphone was actually maxed out on the volume, and I realized that the audio could not be saved. Because I love you guys so much on the channel, I decided to record the video twice instead of actually opting not to give you a video today. So grab a piece of paper and let's go. Hello and welcome to the Bazooka. My name is Dr. Moses Kazevu. This is a series that on my YouTube channel where we look at 10 OSCE stations in one clinical course. This is season 4, episode 3, surgery. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon so you never miss on such amazing content every time I post. Drop a like, drop a comment to Zambia and beyond. And remember, before we dive into this may contain graphical images, so viewer discretion is advised. And remember, these pictures are only for teaching purposes. You already know the drill to this series. You may pause the video at any moment to write down your answer, screaming it at the screen. And if you are watching it with a friend for whatever reason, tell it to your friend and argue about the answers. So let's get into the meat of this discussion. Station 1. Identify the procedure shown in the image, list the indications of the procedure, list 4 complications of the procedure. How would you make sure that the device is in the right place? You may pause the video at this particular moment. And here comes the answer. So this is a laryngoscopic endotracheal intubation. As you can see, they're trying to intubate this patient. And this can be done for mechanical ventilation during surgical theater procedures that are going to be using general anesthesia. It can be done to provide a patent airway and prevent aspiration for those patients that are unconscious. It can be used for positive pressure ventilation, for example, in a patient with a flail chest or patients with respiratory failure. It can also be used for airway management when you have tried to ventilate them by mask and you have really failed. Then complications of the procedure include direct injury to the dental and the oral soft tissue structures. You may also have hypertension and tachycardia, which is a reflex activity. You may also have aspiration of gastric content. You may have failed intubation and inability to ventilate the patient. Then, of course, the best way to actually determine that the tube is actually in situ is actually to do carbon dioxide capnometry. You can actually measure the levels of carbon dioxide. If you don't have this, you can actually auscultate the lungs, and there's equal bilateral air entry with vesicular breath sounds. Of course, you may also see some misting of the tube, but of course, this is not a very reliable thing to depend upon. Then station 2, describe what you see in the image. What are the indications of the above apparatus? You may pause the video and write down your answer. Here comes the answer. So this is an individual that has a tracheostomy tube in situ, and the indications can be divided as congenital versus acquired. Congenital, where you have subglottic upper tracheal stenosis, laryngeal webs, tracheoesophageal anomalies, bilateral choanal anomalies, laryngeal hypoplasia. Then you have some acquired indications such as trauma. It could be in the background of bilateral vocal paralysis, foreign body aspiration, airway edema that can be caused by trauma, burns, infections, or anaphylaxis. Station 3. A 27-year-old female patient presents to the surgical emergency department with history of vomiting. As you are clerking, she gives you the x-ray shown in the picture. Which view of abdominal x-ray is this, and what does it show? What 3 other questions would you ask in the history? Give 3 possible causes of the above pathology. Give 2 compensatory mechanisms of hypovolemic shock. You may pause the video. It's never really a surgical exam if you don't have x-rays. And here comes the answer. So this is a woman that is giving you this x-ray. Of course, she's vomiting, meaning she has some sort of obstruction. And it's quite clear from this x-ray that we can see that there is some dilatation of the bowel. As you can see, how do you know that this here is a supine x-ray? It's very easy. Let me just show you in the next picture here. If you get an erect x-ray, you get a lot of these air fluid levels, as you can see on this x-ray. And you see this patient here who has this multiple air fluid levels. This is very common in the erect x-rays, because the assumption is that when someone is standing erect, the air has a less density to settle up, fluid has a greater density to settle down. Then with the supine type of x-ray, these ones tend to just have pretty much the dilatation of the bowel. You also do notice these things that are traversing the entire lumen, what we call the valvulae conventae, which are usually typical with small bowel obstruction. So this person here has taken a supine x-ray, which is going to be showing you this dilated small bowel with visible valvulae conventae. Then other questions you would ask: history of abdominal pain, history of constipation, absolute constipation or obstipation, as well as a history of abdominal distension. 3 possible causes, you may divide them as extramural, peritoneal adhesions, very common, abdominal hernias, very common, intramural causes such as intussusception, fairly common, and intraluminal causes such as gallstone ileus, not so common. Then remember, whenever someone goes into hypovolemic shock, the body's trying to put itself in a way such that you can keep perfusing the vital organs. So one thing that's going to be there is that there's going to be this increase in sympathetic tone. Then this is going to increase the heart rate, which is a positive chronotropy, is going to be increasing the cardiac contractility, which is a positive ionotropy. And of course, there's going to be an increase in the peripheral vascular resistance. In addition to this, there's also going to be vascular redistribution to the vital organs. So the organs that often tend to suffer are going to be the GIT and the skin, because they're not really considered as quote-unquote vital organs. And then coming to station 4, a 30-year-old male with a history of urethral discharge a year ago presents with difficulty in passing urine. The image below shows the investigation done. What investigation was done? What is the pathology being displayed? What could be the causative organism? If you saw the patient whilst he had urethral discharge, what investigation would you have done? If he is in retention with failed urethral catheterization, what procedure would you do? You may pause the video at this particular moment. And here comes the answer. So this is a retrograde urethrogram, and it's going to be showing this segment of irregular beaded narrowing in the distal bulbous urethra with opacification of the left carpal duct. Then this is most commonly caused by Neisseria gonorrhea because of this history of the discharge that this person had a year ago and difficulty passing urine. And of course, if they came in with a discharge, you want to do a pass microscopy culture and sensitivity. Also get a nucleic acid amplification test on the same pass to actually check for the nucleic acid of this Neisseria gonorrhea. Then if they fail to catheterize, you'd want to perform a suprapubic catheterization. Coming to station 5, a 57-year-old man underwent the following abdominal procedure for the purposes of feeding. He has had a history of progressive dysphagia with marked weight loss. What procedure was done? Mention at least 4 grades of dysphagia. What 3 investigations would you do to find the cause of dysphagia? The patient was aggressively fed. What complication can arise? You may pause the video at this particular moment, and here comes the answer. So this is obviously a gastrostomy, and the grades of dysphagia are going to be graded as 0 for normal swallowing, 1 if they're able to swallow some solid food, 2 if they're able to swallow semi-liquid food, 3 if they're able to swallow liquids only, and 4 if they have absolute dysphagia. The investigations I'd want to do is an endoscopy, a barium swallow, as well as an esophageal manometry. Then remember, if you feed this person too much, a lot of calories, they may develop refeeding syndrome. How I like to remember this is, for example, if you're studying for an exam and you decide to read the entire syllabus the night before, and you're trying to fatten the cow, then your cow develops refeeding syndrome. So use that analogy to actually remember refeeding syndrome and not really overfeed patients. Then coming to station 6, a 70-year-old man presents to the orthopedic clinic complaining of severe knee pain for 3-month history. As you're taking the history, he shows an x-ray displayed in this picture. What is the most likely diagnosis? What 4 radiological features would support your diagnosis? In your history, what 4 risk factors would you elicit? You may pause the video. And here comes the answer. So this is a man that's 70-year-old, and they've come in with knee pain. The most likely thing that's going to be there is osteoarthritis of the knee. How do I know this? As you can see here, there is this loss of this joint space. I'll show you a picture of a normal x-ray in the next slide. You also have this osteophytes that you can see over there. So the 4 features that you look for, of course, you can remember the acronym LOSS. L for loss of joint space, O for osteophytes, S for subchondral bone cysts, and the other S for subchondral bone sclerosis. So as you can see here, even in this bone, the density doesn't look as like that of a normal bone. Then of course, risk factors that I would like to elicit, for example, obesity, a family history because it's genetically linked. The race of the patient is very common in Asians. Any history of joint injury or overuse I would also like to ask for the occupation of this person. And of course, the medical conditions like hemochromatosis and as well as inflammatory arthritis. Here is an x-ray of a normal joint. As you can see, you have this uniform space in the joint, while as here with osteoarthritis, you have this loss of the joint space. Then you also have these osteophytes that we can actually see over here. So that's osteoarthritis of the knee. In station 7, a 36-year-old Rastaman from Chivolia compound presents with darkening of the toes of the right foot. The examiner palpates the dorsum of the foot as shown in the picture. What is the diagnosis? What are the 2 other types of the condition? What 4 risk factors would you elicit in the history? What is the examiner palpating for? Mention 2 investigations that you would do in this patient. So you may pause the video. And here comes the answer. So this is a 36-year-old Rasta man from Chivolia. Most likely he smokes. So he's developed gangrene, most likely dry gangrene. As you can see, the toes are appearing dry. And it's most likely secondary to peripheral vascular disease. The other types of gangrene include wet gangrene and gas gangrene. I would like to ask for a history of diabetes, the diet of this person if it's high in cholesterol, history of any chronic kidney disease, history of family history of vascular disease, as well as a history of smoking. The age has already been mentioned for us. Then, of course, what is the examiner looking for? So the examiner is actually trying to palpate the dorsalis pedis artery. Then 2 investigations that you would do for this patient: a Doppler ultrasound to determine where the blockage is, as well as an x-ray of the lower limb to see if there's any involvement of the bone. Station 8, the specimen came from a post-laparotomy and a sigmoidectomy patient. Also, a Hartmann colostomy was done. What is the diagnosis? Mention 3 symptoms that this patient might have presented with. What 3 risk factors can be elicited in the history? Mention 2 investigations that would have been done. What is Hartmann's colostomy? You may pause the video, and here comes the answer. So this is a CA colon. They may have rectal bleeding, they may have weight loss, they may have altered bowel habits, for example, diarrhea or constipation. If it's actually much more distal, they may sometimes even have tenesmus. Then they may also present with intestinal obstruction. Risk factors are going to include a family history of colon cancer, a history of ulcerative colitis or Crohn's disease, long-standing history of smoking, and a long-standing history of alcohol. Then 2 investigations that can be done: a flexible sigmoidoscopy or a proctosigmoidoscopy, an air contrast barium enema, and a fecal occult blood test. So remember, Hartmann's colostomy is pretty much a type of surgical procedure where we perform a colectomy and remove part of the colon. Sometimes we do even remove part of the rectum, where you do a proctosigmoidectomy, with the remaining rectum actually being sewed out in a pouch, which is known as Hartmann's pouch, and then the remaining part of the colon is going to be redirected outside the body, and you form a stoma. Station 9, you are the attending doctor to a 55-year-old patient who has been admitted for evaluation. What are the 3 examination findings that can be elicited in this patient? Mention 3 investigations that can be done in this patient and why. Itemize the T component of the TMN staging. You may pause the video, write down your answers, scream them at your friend, argue with your friend, and here comes the answer. So this is a peau d'orange, which is pretty much the peel of an orange. It's a French term. You may also see nipple retraction, as you can see here. And of course, this breast is markedly distended, and you have this asymmetry of the breast compared to the other one. So those are the 3 things that you may elicit. Investigations include a mammogram, because this patient is obviously above the age of 35, so the breast density is different to someone who's less than 35, and generally even the size of the breast is different as compared to someone who's less than 35. We want to do a chest x-ray to rule out any METs and FNAC because it's cheaper and it's less invasive, and you're able to detect certain malignant cells. And of course, a core needle biopsy for the histology in case where the FNAC comes out unrevealing. Then remember the TMN staging. T is for the tumor size, so T0 is no palpable tumor. TIS is a tumor in situ. T1 is a tumor size that's 2 centimeters or less in its greatest dimensions, but it's not fixed or tethered. T2 is a tumor size that's 2 to 5 centimeters in its greatest dimension. There is some nipple retraction or tethering. T3 is a tumor size that is more than 5 centimeters, so 5 to 10 centimeters in its greatest dimensions, and has some infiltrations or ulcerations. Then T4 is any size that is invading the skin or chest wall, not including the pectoral muscles, about 10 centimeters in its greatest dimension, ulceration that's greater than the distance of the lump, as well as skin edema or skin ulcerations or stellate skin nodules that are confined to the same breast, or if this patient has inflammatory breast carcinoma. Then coming to the last station, which is station 10, a 25-year-old presents to the hospital with acute abdomen and intraoperative gangrenous bowel due to irreversible inguinal hernia. The following procedure was done as shown in the picture. What does the image show? Why does the skin around it look excoriated? What 4 complications are associated with this procedure? Why does the patient lose weight over time? So you may pause the video, look at this image, write down your answers, and here comes the answer. So this is an ileostomy. How do I know this? Obviously because of the skin excoriation, and you have this protruding erythematous bowel with excoriated peristomal skin. The excoriation is going to be due to the contents of the small bowel because they have these enzymes that can irritate and digest the skin. Then complications include a peristomal hernia. You can have the stoma retracting. You can have stenosis leading to constipation. You can have prolapse or intussusception. You can have stomal diarrhea. You can have electrolyte imbalance. And the reason why they lose weight over time is because you get this reduced absorptive capacity of the resected bowel. And initially when they put the stoma, the patient develops this diarrhea. And also it may be owing to the fact that ileostomy is generally a high output and may not give a chance to absorb the nutrients that are essential for digestion and even for digestion to take place adequately. Then here's a bonus question. Leave your comments in the comment section below. I will leave a pinned comment to the person that gets it first correct. What is the name of this instrument? What is it used for? And what conditions can it be used to diagnose? If you really enjoyed this video, consider subscribing to the channel. Hit the bell notification icon so you'd never miss on such amazing content because I upload each and every day of the week. Don't forget to subscribe. Hit the bell notification icon. Drop a like, drop a comment, share the link to someone who doesn't know of the channel. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.